Good afternoon and welcome to Population Health Management, Forming Partnerships for True Interoperability, a complimentary webinar from healthsystemcio.com. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of healthsystemcio.com, and I'll be your moderator today. We encourage you to ask questions. You can send them in at any time in the lower right-hand corner of your screen, the Q&A box. Leave the default set to all panelists. Send them in when you like, and we'll pose them to our speaker later in the program. You can download the deck using the URL on your screen. There's a shortened URL at the bottom of all slides, and I'll also send it out in the chat box. So you'll have plenty of chances to get the URL. And we are recording this event, so we'll have an archive available within 2 business days, if not sooner. You'll get an email when the archive is ready, and a separate registration is required. Just so you see how we're going to spend our time today, we're going to go about 40 minutes. First, we're going to hear from Ed Ricks, VP and CIO of Beaufort Memorial Hospital, and then we're going to have our Q&A with Ed. So without further delay, I'm going to turn it over to our good friend Ed Ricks. Ed, thanks for joining us again.
Okay, thanks, Anthony. I appreciate it, and thanks everyone for joining in. I'm just going to talk for a few minutes about what we're doing here at our hospital and what population health management means to us. I think everyone's got a little bit different definition of that, and I'm going to apologize in advance. I've got a little bit of a cold, so not only will I probably sound different than I should, I'm probably going to sound dumber too, but sorry for that in advance. I'm going to do the best I can here. Just to kind of put a frame of reference around who we are as an organization so you can put it in context with your own organizations, we're sort of what I call kind of the perfect community hospital still. So we're a 197-bed, private, not-for-profit community hospital, and we understand our mission is to, serve our community here. We use Meditech here just for reference purposes, but this isn't about technology at all really today. It's really about what we're doing from a strategic perspective and how I think the CIO role has really changed over the last 10 or 15 years to kind of position us to be really influential, I think, in some of the forward-thinking things that we're all doing in our organizations. It's hard to tell this little picture of our hospital here, just so in case you don't know, we're in Beaufort, South Carolina. Beaufort is right on the coast, and literally our hospital is on the water. That's Intracoastal Waterway, and you can just see in the background there's a little bridge back there, and that bridge is actually the bridge that Tom Hanks ran over when they filmed the movie Forrest Gump. So in the movie it says the Mississippi River, but in real life it was filmed here, and it was the Beaufort River. So that's kind of one of our claims to fame here, but beautiful place to live. Very active community. We're about 2,000 users in the hospital here. We've got kind of the full complement of services. We're not a tertiary care facility. We certainly recognize when to refer patients out, but just short of that, I think, for everything else. And have our volumes keep increasing all the time. I'm sure you guys are all experiencing the same things. And we've done some cool things with technology here, but I think it's always, for the right reasons. It's not just to have neat projects. It's actually to improve the healthcare delivery process, which is sort of what we see our role here from an IT perspective. So here's what I want to talk about for just a few minutes is sort of what's happening in healthcare. Again, nothing new for any of you guys. I mean, I know you're very engaged in this and know more than I do. And then what our platform looks like today, just from a technical perspective, but that's really brief. Really, I want to talk about what I see the CIO role has become over time and how we're sort of positioned to really be helpful, I think, in what I'll call true interoperability or population health management. And sort of the definition may change for what's relevant for your organization, but it's really about forming partnerships. And again, far from technical, although there's a lot of really cool technical things that have to happen, but there's more to that story, I think. And then we'll just a quick little wrap up. So out of the news, this isn't coming from me. You guys all know this stuff, what's happening with healthcare reform. And to me, it's really should just be called lower reimbursement. But no one can argue, whether you like the Accountable Care Act or any of the things that go along with that, as a nation, we spend too much on healthcare. So somehow we've got to figure out how to drive costs down, and that's on creating efficiencies. And I think IT has always and will continue to play a more increasingly important role in that, driving down costs, creating efficiencies, whether that's through better communication amongst caregivers, through the transitions of care, all the things that we can sort of help control. And clearly we're all sort of looking at this, what's it mean to be reimbursed on volume versus reimbursed on value, and what that's going to look like. I'm not proud to admit, but we're one of the many, many hospitals who are getting a small hit in our Medicare reimbursement this year for some quality scores from like 3 years ago before we even realized we were supposed to be tracking some things, I think, and so we've got a lot of things in place that have mitigated that, but regardless, we're still paying that price this year, and I know we're not unique in that, many, many organizations. So how do we sort of still focus on the volume base that we need while we're starting to prepare for all value-based or at least more value-based reimbursement? And then what we've done is, while we're not truly an ACO here, and some of that's our geography, and maybe someday we'll participate with one, we feel like we can still act like one where it makes sense for us. And by that, it means talking about who are our at-risk populations and what are we going to do to manage those folks differently, whether we're being reimbursed specifically for them or have some kind of agreement with managed care or Medicaid or something like that. It's still how can we drive costs down and create some efficiency for those groups and how it directly impacts us, and I'll talk briefly about that. So for us, when we do our strategic planning in the organization, we have 5 key elements that we created, and then some, I think about 11 or 12 kind of operational pieces that go across those 5. But one of the things that just kept rising to the top is what are we going to call population health management? What are we going to define it as? And what is that? How does that impact look to us in the long run? Things that we can do today to operationalize things and things to be planning for in the future. And what we've decided here, and basically, if you talk to software vendors, there are many, many, many software vendors in this space, and so I'm not here to talk about any one of those because they all have a different definition of what population health management looks like, and essentially it is what fits into their definition of their software package. So for us, we want to be very practical. Is we've got a few what we would consider at-risk populations, even though we're not an ACO. One, and I know this is not unique for us, but our employees independent, so we're completely self-funded for our health insurance, and that's one of our greatest expenses on an annual basis. So if there's anything we can do to improve the wellness, lower the costs, and still have the positive outcomes that we want, that's an at-risk population for us that we can have immediate impact on. Another one clearly are the penalty readmit patients. There's 3 or 4 of those diagnosis codes now, but there's 3 or 4 more coming into play over the next year. So getting our arms around those people, how do we manage them when they're here? How do we manage them, more importantly, when they're not here so that they don't come back as a readmit, and those numbers that end up hurting our reimbursement and, frankly, hopefully improve their quality of life and the outcomes on that. And then we have a large population of unfunded patients in our community that we certainly take care of. So how can we manage that as more of an at-risk group, because we may not be seeing reimbursement at all from these patients. So anything we can do, again, to create efficiency, drive costs down, to us, we consider that an at-risk patient. So if you're an ACO, this means a lot more to you, and you've got your arms around what that looks like from a reimbursement perspective. We're looking at it as we can act like an ACO in our community, have an impact on these populations, even though by definition that's really not what we are, but we still do have these at-risk populations. Just briefly, this is about my only technology thing at all, is, it does take a lot of things in place. You need the components to be able to be what people would consider interoperable, and I still see this transforming over the next 3 or 4 years, or maybe 10 years for all of us, I think, from a more national level. But I mentioned we're a Meditech hospital. We do have a few best-of-breed applications. We're actually sort of migrating away from that. We've started that project now to get to more of a single record, single EMR approach across our whole continuum of care that we have control over, but there's a whole host of things within our community of our patient experience that are not controlled by us, so there'll still be all these other platforms out there. We do have, obviously, an integration engine. We do a lot of work with that, bidirectional with things. We've done all the meaningful use things that you've all done. We've actually put in a community HIE of our own, so we actually own and manage that from the hospital. We participated with our state HIE, still want to and be a good steward of that, but the reality was we weren't finding a lot of clinical relevance. Really, the nice thing was to complete that picture in our community. So independent physician practices, our own physician practices, our hospital information, have that kind of be a seamless within an HIE. So that's why we decided to implement that about 18 months ago. Obviously, a patient portal, which I think we've all done something for that. But what's really cool is that I think that we're hoping to tie in our patient portal as the communication conduit between the patients and the care navigators on the back end as we do this population health management platform. And I think that's where patients will really see some benefit of a portal, other than today all the didactic information that we send out. Really, it's how do we engage them and get them to use the portal, but it's really engaging them with their health care, I think, is probably where the future is going to be. And I'm excited that we're going to take that step, and luckily have kind of put the building blocks in place, we think, to make that all work. But first, let me talk about what I've seen as a CIO and how things have changed over the years, and it's interesting to me. So this, I'm going to call this the evolution of a CIO, and just bear with me on it, but this is subtitled A Picture Story. So very few words here, but I think you'll sort of get the picture of what I'm talking about. Maybe this is different in community hospitals. I've worked in 4 community hospitals over the last 18 or 19 years now as essentially the CIO role in all of them, and what I've seen transpire, and for good reason a lot of it is, but you know, remember the good old days. So this was back pre-EMR, right? We all had our IT systems because we did registration and admissions process. We had medical records, certainly billing and the general financials and all those things, but we thought it was a hard environment to work in. I miss those days immensely. You know, we could kind of be on cruise control, and we did a lot of really cool things, but it was completely different. And one thing sort of changed that. You know, in 1999, a lot of people were already ahead of this curve, but the IOM report came out about all the errors that we create in healthcare. And one of the answers, there's many components of this, but one facet of this is better IT systems that, you know, if we create things that are repeatable, that we can reduce errors, we can do clinical decision support, all those things, and stop making the med errors. I've used this picture before, and some folks know me. My wife is an RN at this hospital, actually, and they asked me if that's a picture of her when she's angry at me, and, you know, my answer is, of course, don't be silly. She's got brown eyes, but I've seen that look, I can say, before, and that's a big change. Then what happened? You know, about 7 years ago, we hear of this meaningful use, or ARA first came out, and how do we define meaningful use? Well, here's how I define it. It was a first coup for the vendors. It was an awful lot of work for all of us, continues to be a lot of work, some of it for the wrong reasons, unfortunately, but man, we've been busy, all of us, and I think you guys can all recognize and realize the things that you've done over the last 4 or 5 years. Even if you had a pretty mature system in place, the changes that had to happen, or your vendors had to make changes so they could accommodate all the other customers, it led to an awful lot of work just to meet meaningful use. I hate talking here to the physicians or the rest of our senior team or the board about we're doing this because of meaningful use. That's, to me, completely the wrong answer. But the reality is, just like all the other compliance things we have to make sure we handle well, we have to meet meaningful use, and we had to do it as an organization. So we do have to meet those objectives, as silly as some may be, and they're certainly changing over time, and I think that we're starting to go down the right path with those changes, or at least the proposed changes. It was a ton of work. But here's the thing, it was more than just work, right? What we've really had to start to do is lead a cultural change. So we can implement systems. That's what we've all done a really good job of for a long time, and every organization. There's some great IT departments and some brilliant leaders, but it's not implementing systems, it's leading cultural change, and it's very difficult to do that, and maybe in healthcare more difficult than many other industries where things are widgets and not people that you're taking care of. I think that overcomplicates things and makes it very difficult, and that cultural change. So you can't just, you know, put that modern rocket on that dog. It's not going to fly. It's the change, the cultural change that's been really painful. But then we go on, right? So we've been lucky to be part of those experiences, and most organizations have had this position for a long time, or elevated the position of CIO. You're not a department director, maybe reporting to finance, which can work well in some environments, but I've just found that over the years, actually being a member of the senior team, being someone who reports directly to the board and to the CEO can make a big difference. And you're looked at now as sort of one of the experts because you've got the perspective of both ends. You know what the systems are available of, you know how to create efficiencies and how to implement, and you've got the healthcare background now. So you're not necessarily a clinician, although I know a lot of my friends now in this role are clinicians, I'm not, so everything I know clinically I've learned from watching TV shows or something, but we're well respected. I think that's the key thing, is that we've got the background and the experience and the credibility, maybe as much as anything else, that you're listened to and you're sitting at the table with all the right people, I think. And what I found really interesting and exciting, well, maybe we do some things backwards here, but like our strategic planning process with the board over this last year or so, I was one of the leaders of that process. So not from an IT perspective, but from an organizational perspective. And I know every organization handles that differently, but it's really good. And I talked about having those, 5 key strategies that we're going to focus on for the next 5 or 6 years for us. And then we had about 11 or so disciplines that sort of intersect all of those. 2 or 3 of those were directly IT related, and we see where that touches essentially every strategy that we try to implement, and embrace that actually and try to use that to our advantage. So that's been kind of fun. The next is, in the evolution, is now, so you are more than an X's and O's person, I think, and truly I think that we've all gained a lot of respect as more of a healthcare strategist over the years, which is fun. I mean, it's a great place to be. Our focus isn't just nursing. Our focus isn't just the physicians. Our focus isn't just creating efficiencies or financial, what the bottom line looks like. It's all of those. How do we blend them together? And sort of what I have to remind myself of a lot, and others I work with here, is, it's all about balance, right? So you want to do the right thing for everything, but sometimes it's balance, and you can't tip the scale too far in any one direction. And I think that we're recognized as a group of professionals over time to sort of growing into that role a little bit. And that leads to one other thing in both your organizations and I think your communities actually, and that is the ability to influence. So now we've sort of got the respect as a strategist. We've got the background and the credibility, certainly. I think we've proven that we can all do really good things and move forward. But now we got to use that, right? So now you've got the ability to lend influence to what's going on in your communities. And in ours, and maybe we're a little different, but I think we're probably pretty similar to a lot of others. There are many, many different organizations or people who lead to this true population health management. It's not just our owned entities. It's the nursing homes, it's the home health care. It's in our community. Honestly, it's the churches that have a lot of influence with people, and some of the other things and components that fall into that. But you've got to sort of tie that all together if you're going to manage people when they're not in your organization anymore. So I think that's what's important, is take what we've developed over the last 15 or 20 years, and even if you're newer than that, I think that you've gotten thrown into it so quickly and learn to get to that same point, and let's leverage that, use that influence and that ability to work with all these people. Clearly, we've got all the software vendors and relationships and partnerships that I like to talk about. So, we've got hundreds of, I guess, vendor relationships probably, but a handful of what I would consider partner relationships. And those are hopefully the people that you're working closely with as you sort of build out these strategies to support what's going to look like interoperability or population health management in the future. Obviously, our user partners, and it's the physicians and the clinicians. We always want to be on top of what it looks like from a financial perspective and just operational and things like that, but clearly it's how do we take care of these patients, how do we improve the experience for the end users, how do we get information that's relevant and deliver it to the right person at the right time, so that's not an overabundance of clinical information, but I can make intelligent decisions based upon that. And then, as importantly, how do we do that when folks aren't here anymore? I talked about, who do you have to partner with, and for us here, obviously, it's our hospital and it's the physician practices in our community. We aren't really close to another hospital, so there is some relevance to other hospitals for us, but it's maybe as much relevant that it's all of the things in the community, which are other physician practices. We do refer out for tertiary care, and those patients go there, and they obviously come back to our community. So there's something there, the data's got to move back and forth, with that patient in a real-time environment also for this to be effective. But it's not as big of a piece as what's in the community. And then, like I talked about, all the other levels of care that folks move to, either whether before they become a patient in our hospital or after we discharge them, they go back. And if it's in a nursing home or some kind of an established, home that's got health care associated with it, or just home health, which is happening more and more. And I think that even though we don't own or operate a home health agency under our umbrella, we have to work closely with those folks to complete the picture and sort of manage through that piece. And then local public health, we've got a couple of big institutions here that we've partnered with, because they also help manage some of the same patient population. And then as you get to more community and bigger, it's, what is our state hospital association doing? And I mentioned, our relationship with their HIE, and we want to be a good steward and participate with that. I hope there's financial sustainability for it. I'm not sure there is, to be honest with you. And I think we're seeing a lot of those sort of fade away now that the federal subsidy money's going away and there's no business model that sustains it. And that's why we created our own internal HIE here, I think, just so that we knew we had some control, we'd have it. We understand it's not a money-making proposition, not intended to be. It's just a way to improve clinical communication, and so we'll just bear the cost of that because it's the right thing to do. And then when I was talking earlier about, patient engagement, we've all talked about that for a while, and I'm still not sure if I understand what it means, but we're going to be tasked with getting folks to do the right thing and manage their health care when they're not in the organization anymore. And I think if we can get to that point, that is how you really truly get to population health management, at least by our definition of it. So what's the incentive? What's in it for the patient? And I think the way we've looked at it is how can they communicate back and forth with us when they're no longer here. So I guess kind of to wrap up a little bit is, what are the things that we've done? I think the evolution of the CIO role and just the IT at the hospital in general, and not just any one person. I think just, what we've elevated to over the last 10 years, besides being a lot of work, puts us in a unique position that we can be involved in these relationships, and whether that's with the vendors, with the clinicians, and I think we have really great relationships now with medical staffs and the nursing staffs in the hospitals and the other clinicians who touch these patients. And then it's the transitional care thing, so it's how do we also talk and work with those folks outside of our, you would think, our sphere of influence. I think we still have a sphere of influence over some of these areas, and communicate with them, get them engaged, understand that we need data to go back and forth. So that's the technical piece. That's the part that we can clearly control. But I think it's just building those relationships that we're uniquely set up to help with and can clearly add value, And so I figure I always have to add value or I'm not doing my job, and I think everyone feels the same way. So I feel great when we create an organizational efficiency. That's an easy thing to sort of measure, and maybe there's an ROI or something to that. I don't go looking for ROI on things, but it's nice when you've created efficiencies internally or externally and can attribute it to the technology. What's really good is if you can you contribute to the cultural change that's the right change, for the right reasons. As painful as it is sometimes, that happens through an implementation process. It happens through really good communication, I think. And trust me, I screw up a lot of things here, and so these are just my lessons learned, and what I know can be more effective in the things going forward. But leading that cultural change, that's probably, I really think it's 90% of our job, really, always has been, is trying to get people to do the right thing for the right reasons and understand that. And then the final impact of all that is the care delivery process, and that's beyond the walls of the hospital and the organization, and how you start to create a care plan and manage people while they're not in the hospital so that you can keep them out from a readmission, let them be healthier, which is really what the goal is. And so that's what population health management looks like to us, is identifying the population of patients, many different unique populations, setting up some sort of a care plan that they should be following. So if you're a discharged CHF patient, that would certainly look different than just a wellness care plan for our employees, say, or maybe a subset of our employees who happen to also have diabetes, which is one of our biggest comorbidities in this area. So how do we have a care plan that they can be managed through, automating that, which that's the technology piece, and then bringing the patient into that automation so that their conduit is through the patient portal or some sort of, secure communication. Creates a relationship, it creates a bond, creates efficiencies for the patient and for the care managers on the back end for us that are kind of working with the exceptions of people who fall through the cracks of those care plans, always I'd say, it makes sense if you think like a patient. Anything that you're implementing or any of the relationships that you're fostering for this stuff, think about it from the terms of the patient perspective is, where will I interact? How does it help me? How does it improve the care process I'm going to get? And that's always a valuable thing. People used to always say, think like a doctor, which is also important, I think, because they're one of our constituents. But if you think like the patient on all of that, I think you'll start to work towards more true patient engagement long term. And then always the last thing is take risks. I always tell the folks here, if you're not breaking things, you're not trying hard enough, so don't be afraid to get out there, get in the public more, work with those groups. I think the patients, the physicians, the other clinicians, obviously the other folks in the community that have an impact on that same population that aren't owned by you, I think the more involved you can get, that's great. And I know it's hard with all the day-to-day stuff that's breaking with us all the time or that we're working towards and new requirements or mandates or something, but I think there's a really important piece of that is just to be willing to get out there and take that on. And I think, Anthony, if I could click one more, I think that was the end of it, So it's, again, not a technological discussion so much as it is, I think, just the pieces that have to be in place from a technology, from a culture, from an infrastructure and a community perspective that we have influence on that are going to play into us being very sustainable, for a long term. And that's a financial component, that's a clinical component, and that's our community component.
Very good, Ed. Well, thank you so much for the presentation. Now we have a little time for Q&A. So as I mentioned, you can type your questions into the Q&A box, leave the default set to all panelists, and we will take a look at those. First question, what are the incentives offered to provider and patients you are exploring or using for better patient engagement?
Yeah, that's a great question because we do talk about that. So besides the incentive of we're hoping to improve your lifestyle and your long-term outcomes, like for our employees that are on our health plan, we can use both incentives and disincentives. It's the same thing that meaningful use is. There's the carrot and the stick, right? So if you participate, we can reduce the piece of the premium that you pay for, and that's legal. We've checked into these things. And just the opposite, if you choose to not participate with this care planning, then we can actually change the premium amount for you, and it will have a negative impact on you. A lot of people have gone to these high deductible plans or something, so they're a little bit more engaged already because if there's anything they can do to drive cost out of their health care, that's a bonus to them. We want it to be both. We want to drive cost out but keep the quality outcomes there, and that's the tricky part. So those are some of the incentives that we've looked at. We've already done some things a lot of people have, like if you are a smoker, that's like a 10% addition to your health care premium that you pay every month because we know that long-term that's going to cost us a lot more. So non-smokers get an incentive, essentially, at a lower premium rate. So when we roll this out to employees and their family members, we will look at some incentives because we do want people to be engaged. Now, for other populations, it may be different. We may not give true incentive like that, but it is a way to manage their care better. And I think that that's the way we'll talk about it, is that, we want to help you remain healthy, not come back to the hospital for readmission of the same diagnosis that you have because we think you can lead a better lifestyle. So we'll connect you. There'll be other things, I think, that are rewards that a lot of folks have already done with their portals, So if you're participating, yes, you can track things over time. You can enter your own information. You can get prescription refills, some of those other conveniences, schedule appointments, that kind of stuff. So I think there are some wins in there for the patient to engage them a little bit, but I'm hoping it's that communication aspect. So I didn't want to mislead anyone. We're not live with this technological component yet, but all the pieces are there, and we're just sort of working through the implementation right now.
Very good. Next question. You mentioned the idea of partnering with community organizations like churches. Any concerns about that? Who would you rely on to open that door and nurture that relationship?
We've got a few different groups. So we actually have a transitional care department. It's a pretty small group of people here, but it's a couple of nurse practitioners, PAs, and then I think we'll keep adding more clinical staff to manage that going forward. And they do a lot of that outreach, and it's more than churches. Believe it or not, barbershops here have a lot of influence over some of their customers, and this is maybe cultural for this part of the world, but I think it's similar in a lot of communities. So everyone who can forge relationships and sort of use that to their advantage, I think it's really important. I try to get involved. We've got a couple other VPs that are very involved in the community with some of those things, but then this transitional care department for us is really sort of the key people.
Great. Can you elaborate more on the change piece, specifically the role docs play in increasing patient engagement? How did you address that to the docs who feel it shouldn't be their job?
I heard somebody say this, I almost hate saying this for an answer, but we're all on the same team here. And I think from a physician perspective, the way I look at it is everyone who touches a patient under the umbrella of us is an ambassador to that patient. So the physicians play a really key role in that. Even to talk about, here we're implementing a patient portal, here's why it's really important for you. And I don't want them to try to sign them up or, collect an email address or something that's important to do, and we've got people to do it. But if they can speak positively and understand what it means, then I think they are better ambassadors. We do the same thing. Basically, everyone in the hospital, we strongly encouraged all of our employees to create a patient portal account just so they would understand what the mechanics look like, what we have today. We're trying to let people understand what the future looks like for that. And I think, everyone's an ambassador. So physicians play an important role because to most patients, that's a trusted advisor. And whether it's the good side of the force or the bad side of the force, I think that they have a very important role that they play.
And we had another question. How are physicians accepting being part of the system? Anything you want to add to your previous answer?
Some are more accepting than others, I would add that. And, like I mentioned, I think probably the most difficult and maybe most rewarding part of our job anymore is leading that cultural change, and that's a part of it is, getting physician acceptance and adoption. And certainly you got to do whatever you can to encourage them to use our systems, too, and make their life as easy as possible. But I'd say that for the most part, we actually have a great medical staff here, and it's kind of fun to work with these people, but certainly there are outliers everywhere.
You mentioned about ROI and that you try not to focus on it. But in order to be sort of a trusted member of the C-suite, don't you have to show that that is in your mind when you're addressing them and giving advice, and that you don't just want to be one of the department heads that's always asking for as much funding as they can, and therefore they have to look at your comments in light of that fact, that you are interested in the overall health of the business and being a good steward of the money and your investments. So how do you balance those things?
It is hard, and I think that's the right word. I think it's all balance. I certainly understand when we're doing capital planning, obviously I'm working with our group for everyone who's got capital needs and requirements, not just IT, and sometimes it's embarrassing how much some of the IT systems cost or the infrastructure or the $1.2 billion that we're all just reading about, with partners and their new Epic implementation. And when you line that up about, do we need a new open MRI? Do we need, a new building somewhere so we can touch more patients or the right patients or make it relevant? So it's balance, and you're right. So I think that ROI can be important, and some things lead to that. And if it's a hard savings, I like those. If it's these imputed vendor type of ROIs, it's meaningless to me, So if it's truly a savings, that is smart. But I think I mentioned earlier that we're sort of consolidating to more of a single medical record approach over the next year, which I think will be really good for us. But one thing it does, besides hopefully improving the safety and the quality of our systems, it also improves communication with the caregivers, and it creates some efficiency. I mean, we're removing, I think it's 5 or 6 kind of best-of-breed systems throughout that process that actually lowers our annual maintenance costs to go to one vendor on that. So, there is some ROI. We think we're doing the right thing because it's the right clinical thing to do, and it's the right thing for the patients, but also done the right way can remove costs and be efficient. But it is hard. It is a balance.
Okay, very good. Next question. Aren't most potential partners, especially physicians, very concerned that you're going to use their information against them? use things you can hurt them financially, especially with physicians. So how do you deal with that when you're trying to establish partnerships?
Yeah, I think one thing is quality scores are going to be how everyone's measured in the future, whether it's the hospital quality outcomes or the physician-specific quality outcomes. It's going to hit them from a reimbursement perspective, hit us all from a reimbursement perspective. So anything that we're doing, we're trying to improve the quality of the care delivery process. That's number one for everything. It's hard to argue with that, no matter what your perspective is. That's just a reality, and you can't really argue against it. So I think if or at least we're trying to approach from that perspective with everyone. You have a lot of other things, and maybe these are cultural, and maybe it's a bigger problem here than other places, but just like with our patient portal, sending results directly to a patient, some physicians are freaked out by that. They want to be able to control talking to a patient in advance, and for some things that is really relevant, but the reality is that's the patient's medical record. They could come in today and get a release of information through medical records and get that information in real time. So why can't we just automate that process, from an electronic perspective? So people are getting used to those things, but it is definitely change.
Very good. Talk a little bit about the patient engagement goals under meaningful use. I know they're increasing them, and there's a lot of pushback because a lot of CIOs are saying we can't even achieve the small numbers you want, and now you want more. What are your thoughts around that? Many CIOs and hospitals are saying, don't hold us accountable for other people's actions, but what are your thoughts?
I sort of agree with that. It's really hard to be judged by what other people outside of your direct influence do. But if there's anything that we can do to hopefully make that process more effective, I think that it's incumbent on me to do it for our organization. And I'm not a meaningful use expert, so I don't know some of the proposed rules or the criteria as well as a lot of other people do. I've agreed. Just the engagement of using a system that's just sending information to a patient, so what? If people want to look at it, they want to look at it. And especially the way we're measured from meaningful use from a hospital side, measured on our inpatient discharges, that's probably the least likely patient to interact with their patient portal, on a timely basis. I think folks who are maybe more engaged in something else, like through the new mothering process, or we have a joint replacement program, pretty engaged people, outpatient laboratory. I think in our physician practices, that population is going to be a little bit easier to engage because they have a really good relationship with their provider at that point, and it's more of a direct one-to-one kind of relationship, and so they'll be more engaged. But I truly think that to get engagement, it's got to go the next step, is how can that patient interact with their health care, not just use our portal? Because that, to me, it's great. I hope we're doing a good job with our portal. I think we've got a good partner from a software perspective and all that, but it's still just sending information to a patient. Now, what makes it valuable to the patient? Is it the other things that a lot of people are doing as far as, prescription refills, ability to ask for an appointment, and those kinds of things, or is it actually, let me interact with my caregiver on the other end because they're measuring, whether I'm meeting these objectives from a care plan or something, and that's sort of the way we've looked at it for a long time, and I think that's where we're going to see some benefit.
And that's really why CIOs are having such a tough time with this. It's because being effective at patient engagement, population health, you're relying on sort of a non-staff member to help you be successful, and that it's not, CIOs know how to put in technology, but it's this sort of getting people to come and use these things that it makes this such a challenge. Is that correct? And any more thoughts around that before we wrap up?
No, I think you're right. I think it's really hard, but that's probably why take all the experiences that we've gone through for the last, whether it's 2 years or 20 years or more in my case, and how do you leverage that to your advantage, because you do have a sphere of influence. And so, do you touch every patient? Of course not. Do you touch all the components that can touch every patient? Yes, and I think that that's what's really relevant, and hopefully the message I was trying to get across.
Well, very good, Ed. That's about all we had time for today. I want to thank you so much for your participation, and we look forward to having you with us again. As I mentioned, we will have an archive. You'll receive an email when it's ready, and separate registration is required. If you have the CHIME CHCIO certification and you've asked us to report to CHIME your attendance, we will. If you have not, go ahead and let CHIME know you attended. Any of our webinars gets you 1 CEU. Sponsorship opportunities, for information about that, you can contact Nancy Wilcox at the address on the screen. Questions, comments overall, you can address those to me. And you can go to our website. You see the URL there to view our upcoming schedule in the last 12 months of events. So again, I want to thank Ed. I want to thank our audience, and everybody have a wonderful